We are live, please.
So, Harshul, you are muted. Harshul, you have to unmute yourself.
Yeah, I was telling Praful to join. Yeah.
Okay. So we welcome you all to this course.
We are live now?
Yes, we are live. We are live.
Yes, ma'am, we are live.
Okay. So we welcome you again to this course. This is module 2. This course on the Phaco emulsification in difficult situations has been conceptualized by Dr. Harshul Tuck. And module 1 is already over. There are 13 modules which are there in this course, and this is the second module which we are now doing: small pupil phaco emulsification, rings and hooks. At the end of the module there will be 15 questions which you would need to answer, and generally a 5-second window is there for each of the questions. And even if you don't watch or don't answer the questions now, the modules will be there later on the website from the next week onwards. So you can take opportunity of that as well. So over to you, Harshul. Thank you for coordinating this so well for this module 2 on small pupil phaco emulsification, rings and hooks.
Yeah, thank you so much, Namrata ma'am, and entire scientific committee and IFIS for giving this wonderful opportunity. And today we have this module 2 on phaco in small pupil. We all know that doing phaco surgery in a case which has small pupil is really challenging for any surgeon, whatever level the surgeon is at, because of inadequate dilatation and inadequate view, which can cause a lot of complications intraoperatively, like anterior capsule tear, iris damage, posterior capsule tear, vitreous loss, or nucleus drop. So all these complications can be avoided if we use some or other pupillary expander which are available now in market. And so today we are focusing on how to safely do phaco in these kind of small pupil cases. So today we have our moderator, Dr. Rohita Nayak from Nara Nethralaya, Bangalore, and Dr. Neeraj Israni from Navi Mumbai as moderating the session. And it's our great pleasure that we have today none other than Dr. Boris Malyugin from Russia, who is the inventor of Malyugin ring. I call it magical Malyugin ring because it has made our life so easy and so simple. I welcome you, Dr. Boris, and thank you so much for accepting our invitation to be here.
Thank you very much, Harshul. My pleasure. As always, a great pleasure.
Thank you so much. Today we also have another inventor, Dr. Suvin Bhattacharjee from Kolkata, who is innovator of B-Hex ring, which is another beautiful pupillary expander device. We welcome you, Dr. Suvin Bhattacharjee.
Thank you, Harshul. Thank you. I'll be there briefly.
Yeah. And we have another expert panelist, Dr. Suvira Jain, with us, who is a great teacher. And we welcome you, Dr. Suvira. Yeah, you're muted. Yeah.
Thank you. Thank you.
Okay. And I welcome all the presenters, Dr. Rishi Swaroop, my dear friend from Hyderabad, Dr. Srini Adeklon from Kerala, and Dr. Praful Marana from RPC, who is Secretary of Delhi Ophthalmic Society. So thank you very much. And now over to Dr. Rohita and Dr. Neeraj to take it forward.
Yeah. Good evening, everyone. Thank you, sir, for this opportunity. And I'll just share my screen. Just a minute. Is my screen visible?
Yeah, it's visible.
You have to put it on slideshow, Rohita. Yes.
Yeah, fine. Fine.
Just a minute. I did it in emergency now.
You can share your screen, Rohita. Yeah.
Yes, sir. Yes, sir. I'm just sharing. Okay, is my screen visible now?
Yeah.
Okay. Actually, Dr. Harshal sir needs no introduction. He's the brain behind When the Going Gets Tough. And he's the one who conducted 48 episodes of this special video symposium, When the Going Gets Tough, the Tough Get Going, in many international and state conferences, where he gives a younger surgeons a chance to showcase their challenging case and to also learn from the experts. He's a director at the Rawat Eye and Phaco Surgery Center in Jaipur, and also the director of Jaipur Laser Vision Center and Tagore Eye Center in Jaipur. He's also the honorary secretary of Rajasthan Ophthalmic Society, an executive member of IRSI, governing council member of Indian Society of Cornea and Keratorefractive Surgeon, and also the national advisor for Indian Journal of Ophthalmology. He has major awards. He has won the JCRS Rosen Award by the JCRS for the best technical article. He's also invented the hydra implantation technique, and he's invented the tuck modified 25 gauge visco cannula, and also the 27 gauge hydrodissection and hydrostitch cannula. He also won the Innovative Ophthalmic Mind Award by RP Center, the Chikitsa Ratna Award by Rajasthan Ophthalmology Society, and a special gold medal by Intraocular Implant and Refractive Society of India at the Chennai by the Health Minister of Tamil Nadu. He also is a Young Achiever Award by ISCKRS Society 2018. Also the BOA Gold Medal, the Young Ophthalmic Hero Award, and also the Kanwar Vimal Singh Dalbia Gold Medal at IRSI Winter Conference at Feb 2024 at Amritsar. We'll present cases of Malyugin. Over to you, Dr. Harshal.
Thank you so much, Dr. Rohita. Can you stop sharing your
Yes,
screen?
sir.
Yeah, okay. So, as I said, that the small pupil really poses a challenge for any phaco surgeon. So we need to use any pupillary expander device which you feel is safer in your hands. So the device which I've been using for years and which I personally like is Malyugin ring. That's why I call this magical Malyugin ring, because once implanted and in the eye, once the pupil is expanded with the device, it makes our life very easy. So this ring is made of polypropylene, and it's now, I think, over 12 to 14 years that this ring is there in the market. So to put this ring, you need to go there and put some OVD behind iris tissue. And this is the injector in which this ring comes. So this is a classical Malyugin ring, which goes through 2.4 millimeter incisions. And this is the Kuglins hook, which usually it's always better to put it through side port, because you can always maneuver the scrolls better and guide the scrolls, lateral scrolls, once they are coming out. So it has 4 scrolls and it gives an 8-point fixation of iris tissue. So the leading scroll, it goes and it engages nicely the pupillary margin. And when lateral scrolls are coming, you should just either tilt slightly on right or left, so that one by one you can engage scrolls nicely. So here I'm just slightly on my right side here, trying to engage this lateral scroll here. And once I've engaged this scroll, I'm using Kuglins hook to guide the one of the left scroll, so that you have iris tissue there. And the last scroll, most of the time you can take this scroll and engage pupillary margin like this. So once this ring is in place, you'll realize that it lies at the pupillary plane, and it comes in 2 sizes, 6.25 millimeter and 7 millimeter. 6.25 is the one which most of the surgeons routinely use. I also use that one only routinely. So the advantage is now you have a perfect dilatation, a pupil which is almost circular in shape once this device is put. And you can make capsulorhexis of perfect size, which is needed for lenses like aspheric, toric, or these kind of lenses. A perfect centration of the capsulorhexis and perfect sizing is needed. So once this ring is placed, you don't realize that your surgery has become so easy, and you can easily finish phaco, do cortical irrigation aspiration, and you can just put IOL, take out OVD behind IOL optic. So what I do is just go behind IOL optic, take out OVD if you are using OVD to implant lens, and then before taking out the scrolls, you just go ahead and put some OVD in front of IOL optic so that, and then to take out this ring, you must disengage all the scrolls one by one using Kugelens hook. And once you have disengaged all the scroll, either you can use the same injector or you can just invert the Kugelens hook and pull on one of the scroll and it comes out nicely. And after that, you just remove whatever OVD is there in front of the IOL optic, and this finishes the case. So the advantage is that there is no extra incision which is needed like in iris hooks, and it's very gentle to iris tissue, and it provides a stable and uniform dilatation of pupil once this ring is placed. So another case, what I want to show is how you take out the ring through injector. So this is again, the advantage is that you can gauge the size of capsulorhexis nicely, and if needed, you can do secondary enlargement of capsulorhexis before you take out this ring. So this you'll never achieve if you're not using any pupillary expander device. So once you have taken out the scrolls, you put, there's a finger there on the Malyugin injector. So you go there and first you just try to engage one of the scroll with this finger, and again use Kugelens hook through side port to guide both the lateral scrolls in the tube, and then you can take this ring out easily. So this is the way you take out with the same injector, and again take off all the OVD before you finish the case. So this is another case, a white cataract with posterior synechia in which penetrating keratoplasty was done 6 months before. And so here again, what I'm doing here is because I wanted to stain capsule better, so I'm not putting any OVD here, so just releasing all the synechias which are there under irrigation. I thought because of this broad PI which was done, dye will, trypan blue will percolate and it will cause good staining. So that's why I didn't want to use OVD before putting trypan blue and releasing synechias. So after I release synechia, I put trypan blue dye, and this pupil needed some dilatation. So again, go and put some OVD behind. So this is another way I've been using for many years. Injecting this Malyugin ring. This is the cartridge which comes with the IOLs. So this is another way you can, we of course ETO this ring and reuse it. So you can always use this injector for years. I've been using it. It's very safe, and it ring comes out predictably and safely in the same way it comes out through injector. So this is the leading scroll which comes. So in cases where PI has been done, of course, it's little tricky, but again, Kugelens hook helps through side port. So here you need to use bimanual technique. So go beneath the ring and push the iris tissue towards incision, and you push the one of the scroll to engage the iris tissue. So little tricky, but you can always put it in. But once you put this ring, it makes this complicated surgery a child's play in anybody's hand. So here you can see after putting ring, it becomes easy. I take off all the nucleus there, do irrigation aspiration, and you can always shift the ring little here and there, and you can see where the cortical matter is there. And after that, you can put IOL in the bag. And again, I'm enlarging the axis to perfect size before I disengage scrolls and disengage all the scrolls and take them out nicely. So this finishes the case. A case where this was a one-eyed patient, uveitic cataract. You can see it's a very small pupil and synechias were there, posterior synechias. So I just go ahead and release the synechia first, and I'm not doing any extra much stretching of this pupil. But in these kind of little fibrotic pupil, usually it's not possible to put 3 scrolls. So, but 2 scrolls you can easily put. And once you have put 2 scrolls, you can one by one put scrolls there. So there's a third scroll, and again bimanual technique you need to use to engage fourth scroll. But the beauty is that once it's placed, it's again at the pupillary plane and surgery becomes very simple. This finishes the case. One last video I want to show is the use in IFIS. This was the case which had dilatation looked like good, but patient was on tamsulosin. We knew that this is a floppy iris. So in these kind of cases, we don't wait for the pupil to behave abnormally. We just go ahead and put Malyugin rings in the first place itself. So, and this is a 2.0 version of Malyugin ring, which has come up for last 2 years, which has a thinner profile. It goes through 2 mm incision. It has more scroll width, and it's exerts half of the pressure as compared to the classical Malyugin ring on iris, on pupillary margin iris tissue. So again, 3 scrolls go in one go, and last scroll you can easily put. So this is a black cataract. So we can make out here that it's very essential that we have a good dilatation in these kind of cases. So once the case is complete and you put lens and you take out the ring, you'll realize that iris was really floppy, and had I not used ring, I had a real tough time in dealing with this case. So once I take out this ring, you'll realize, look at the way iris start behaving after I take out this ring. So iris start coming the side port. So in cases where patient is already on tamsulosin or other alpha antagonist, you should always use them in the initial phases only, rather than wait for iris to misbehave and then try to put some devices. So I think we have this beautiful device which is of great use in dealing with cases which have small pupil because of any reason. Thank you so much.
Yeah, wonderful videos, Harshal sir. When we have Malignan sir here, I think we can get a lot of tips from him. Sir, what suggestions do you give for a beginner who will want to start implanting the Malignan ring?
I agree that these are great videos, a spectrum of different clinical scenarios, from floppy iris to very small pupil with a peripupillary membrane. I think it would be very important to mention that it's better to use any pupil device, whether it will be a hook or Malyugin ring or B-Hex or any other device, before anterior capsulorhexis is being done. And I think it's very important for the young surgeons because the edge of the capsule can be easily catched by any of these devices, and then you are posing the risk of radial tearing. So I think that recognizing the need of the mechanical pupil expansion and being more proactive and kind of in your manipulations, it's a very clever approach rather than waiting until the last moment and then trying to deal with that pupil when kind of the sequence of events may be already uh, um, falling down and you're kind of in a tight situation. And I think that's one important point. The other thing, I've seen this case with a very, very small pupil, and usually in those cases, I like to, when there is a fibrotic membrane and the pupil is like 3 millimeter, 2 millimeter in diameter, I like to stretch it a little bit prior to insertion of pupil expansion device. I think it also helpful rather than trying to engage the iris with the device that make me more comfortable in having pupil. You cannot have a good dilation usually in these cases, but you have like 3.5, 4 millimeter pupil, and then you are manipulating much easier with that maneuver.
Yes, sir. Sir, in some cases, I like to ask the panelists. In some cases where it is a traumatic case, where the posterior pigment epithelium is stuck onto the anterior capsule, and we want to use the dilating devices, how do you go ahead and separate this posterior pigment epithelium, which is sort of stuck, or do you initially separate these and then only try to implant the rings, or the ring itself can just stretch the.
I do like to separate posterior synechiae prior to insertion of the ring. And usually, in most of the cases, at least in my hands, it's quite easy because these synechiae are not very strong, and with any instrument like spatula or Kugeln you can separate them and then implant the ring. So I think it's advisable to do that prior to insertion of the device.
And what is your experience when the ring actually sometimes dislodges when you're trying to implant the lens, or do you have had such situations, and how to overcome?
Yes, of course. I had a couple of cases. Luckily, it's not a common situation, but it may happen sometimes. Um, and I would like to be very careful in that, and that depends on the situation when the ring is dislodged. If it's dislodged during IOL insertion for some reason, you have to be very careful for the lens haptic not going in between the iris and the ring. Otherwise, kind of the lens will be entangled in that. So if that happens prior to lens insertion, I would rather recommend to correcting that and then going with the IOL implantation rather than leaving it as it is. And it's not so hard to do, but it requires bimanual manipulations usually because you need to retract one portion of the iris and then to visualize the scroll and then reposition it. Sometimes blind maneuvers work, but I would not probably recommend that when you kind of imaginary draw the line and think, okay, this is the configuration of the ring and this is the scroll should be there. And then you kind of try to fish it in a blind maneuver, but that's probably not the favorite, my favorite recommendations to the novice cataract surgeon.
Yes, sir.
I have a question for you, Dr. Boris, and I know it might be a little uncomfortable. I just wanted to know, have you used your ring again, like we use your ring again?
Yes, I was reusing it It's several times. It depends on the environment where are you in. So in some environments, it's not possible to reuse. I had experience in reusing the first version. I have no experience in reusing the second, more thinner one that I cannot comment on that. So you have to be quite careful because sometimes when they give you the ring um, from the sterilization device and it's hot, so you need to wait until it's cooled down. Otherwise, when you're implanting the ring that is warm, so it can be distorted and that will lose its square configuration and become elongated. So that's kind of very important thing to remember, just to keep it cool if that is just coming from sterilization. If it's kind of not freshly sterilized, that's not a problem.
So I had a question as well. Harshul, in your case, the patient with the white cataract with the large peripheral iridectomy and the inferior synechiae, it was a brilliant suggestion to break the synechiae, then stain the anterior capsule, because otherwise you would have an asymmetric and an unequal and a part of the anterior capsule which is not stained. How safe, Dr. Malyugin, do you think it is to actually? Harshul is, we all know, an exceptional surgeon, and I'm not just saying it because he's my good friend, he is. But in a patient with such a large iridectomy, let alone the fact that you've got a complicated cataract there, do you not think it might be a little unsafe to implant the ring? Because when the inferior, when it's opened out inferiorly and the two lateral flanges come out, is there not a significant chance of the iridectomy just ripping anteriorly and become
So in white cataracts, we definitely have two
a
potential
large iridectomy?
scenarios. One is when the dye is injected prior to insertion and prior to viscoelastic injection into the eye. The second option is to inject viscoelastic, inject the ring, and then try to dye the capsule. And with this, I do believe there's a suggestion by Steve Arshinov by injecting the BSS under the viscoelastic to create the space in between the anterior capsule and the bolus of viscoelastic, allowing you to stain the capsule and then proceed with the surgery. So I think that these two options, if possible, I would like to use the first one. However, if not, the second one is an option. And also in Dr. Harshul's case, when with the giant coloboma, there was a very thin bridge of the tissue and then what kind of the iris was stretched.
Yes.
Definitely, there was a little bit risky to see this stretch of a tissue and whether or not it will be broken during the implantation. Harshul did a great job. He was very gentle, but sometimes that theoretically may happen, and you will need to use iris repair and with sutures if needed.
Thank you.
So I'd like to add here that I've used like both the versions of your ring, and I again shifted back to the original version just because of the reason that the newer version is thinner. It has a thinner profile, the scroll width is more, so we can't reuse it more. It's just that two times we can reuse it, but the original version,
You can
yes, 5 to
use it
6
more.
times we can reuse it. Yeah, it's more sturdy. And moreover, Dr. Suvira, I have a lot of cases like you are right that cases where PI is done like in like glaucomatous cases also where people is not dilating and it's little tricky, but believe me, it's very gentle. Yeah, you can always do it. Yeah.
Okay.
And in those cases, of course, it will need bimanual technique because that portion gets stretched, that PI portion, and then you can't put it directly. So you need to pull the iris towards incision and push the ring. So that's the way you can always engage it.
Okay.
So have you done such cases in traumatic dialysis along with meiosis, and you had dialysis which extends or sudden bleeding happens or something like that? And
I don't think that that pupil expansion will influence the extent of dialysis. Of course, if it's very big and more than 3 clock hours, that will make it a bit challenging because the ring might be displaced and you will not be having a very good centration. I had a chance to use the ring in patients with congenital iris coloboma, and interestingly, in these cases, it works quite well. If the coloboma is not big enough, like 2 hours, 2 clock hours, it works very well. If you position the ring properly with the center of the side facing towards coloboma. So it's a possibility to use the device even in patients with some extent of iris defects.
Yeah, I also have many cases of coloboma where I use Malyugin ring. So one of the scroll is towards one side of the coloboma, and another scroll is towards the other side. No, so there's a
Yeah, exactly,
yeah,
exactly.
yeah. So that's how we need to place it.
so when we have placed the 3 scrolls and when we are trying to place the 4th scroll, there is actually a stretch on that particular side. So if that is the time when, there may be a stretch of the dialysis increasing or
So usually it's stretch is not much, Rohita. Like it's very gentle. Believe me, the scroll, the way it compresses, it's very gentle. And I have many surgeons like who have started using it, and from the first use itself, they are so comfortable, you know. So that's the beauty of this device.
sir, any situation where you will advise not to use malignant ring?
Where pupil is dilated.
Yeah.
Fair enough.
Only
Any contraindications in a small
I,
people?
But in a fibrotic, very fibrotic, when the iris is really fibrotic and it kind of cheese wires, or have you had any situations where you put it, it didn't work and you had to take it out?
yes, I did had the situation, but the situation was when the pupil was very fibrotic, and I was using the second generation ring, and it was not possible because it's so pliable. So I removed the second generation and I inserted the first generation, which is thicker, sturdy, and then I would get success. So that's happened to me a couple of times. That's why I do not like use the second generation, which is thinner with this small, very fibrotic pupils. That's definitely. And the other thing, when I see that vitreoretinal surgeons still have a tendency to use hooks rather than any type of rings. And probably this is the reason that when you're not entering the anterior chamber, when you're not kind of manipulating with the lens or doing anything, you need just pupil expansion. So probably for that kind of scenario, iris hooks is a good alternative, and then kind of they require a little bit more manipulations, but I think that are acceptable. So these are scenarios when I would probably encourage using the hooks rather than any type of the ring when you're not opening the anterior chamber and not doing any manipulations with the lens.
Dr. Rohita, there are some questions in chat box to Dr. Malyugin. You can ask them. Then, of course,
I think then Dr. Malyugin would have to leave.
yeah.
Yes.
We've already overstepped his time, but thank you so
Yeah, a
much.
little bit. Yeah.
Thank you so much for being with us today, and that has added a absolutely new flavor to the whole course.
Thank you. It's my pleasure. My pleasure. Always my pleasure to see my friends and communicate with my Indian colleagues, whom I respect very much.
So there is a question from the audience. Is it possible to put this ring in anterior chamber, engage the first scroll in the direction of the PI, and then the rest of the scrolls later, so which may prevent the stretch on the bridge of the tissue near the PI?
The answer to that question is that might be a little bit tricky. It depends on the location of your main incision, because usually when you insert the ring, so you kind of try and engage the opposite part of the iris, which is opposite to the main incision. So we know that giant post-surgical colobomas are mostly located at around 12 o'clock or in the upper quadrant. So by kind of playing with your main incision location, it's theoretically possible, but I don't think it will be very convenient to do that.
There's one more question. What to absolutely not do when using a Malyugin ring or a B-Hex ring for a beginner?
I think every device should be used properly. We have symposiums about dislocated lenses, about improper fixation of implants, but we will never give up using these lenses because these are excellent devices. So as with every device, you need to utilize proper technique and follow certain rules, and you will get success. I would probably recommend to watch a lot of videos to see how that device is working, maybe taking wet labs prior to using any type of ring in the clinical scenario. That will help to avoid any issues and problems. And I think to learn the proper techniques to avoid any mistakes and complications. Theoretically, you may have some bleeding when the small pupil is associated with the neovascularization or neovascular glaucoma. So you are breaking the anterior synechial, and there is a bleeding from the iris. Then in that case, I would probably advise to stop, not to implant the ring, but just to push a bit more viscoelastic into the anterior chamber, wait until the bleeding stops, and then proceed. So, so there are certain maneuvers you can do in complicated scenarios that will help you to manage these challenging cases.
There are two just small tips for beginners because this question was asked. There's before you put this injector in anterior chamber, you should try using it outside itself. You know that whether you are going to use your index finger, there is a button there, no, which you push it forward. So after putting injector, you don't have to make any uncontrolled movements. So either you use your index finger to push it or use your thumb to push it. So there are two ways you have to decide that, yes, I'll put injector like this and I'll use just my index finger like this. And secondly, I think it's very important that to know that it's not that there is one way. You can only just push it. If you feel that you need to withdraw it, you can always withdraw it also, you know. So once you feel that scroll is not engaging the iris tissue, you can always little bit again withdraw it inside and again try to push it. So these are small things which, you learn by using in 2-3 cases. Okay, so I think with this we end this talk. Thank you so much, Dr. Boris, once again.
My
Thank you.
pleasure.
Thank you so much,
Thank you
Dr.
so much, sir. Thank you so much.
Thank you.
I
Bye-bye.
think, okay. I welcome next Dr. Prafulla. Sir, is my screen visible?
Yes, Rohita. Continue, yes.
Our next speaker is Prafulla Kumar Maharana. He is finished his MD and senior residency from AIMS. He's an additional professor in RP Center. He's also the secretary for DOS. He has published more than 395 Google Scholar articles and 163 PubMed indexed papers, and also has more than 50 chapters in national and international books. He won the Best Surgical Technique Award from Ranzo, Australia, a Young Achiever Award from ISCKRS, Ajit Babu Maji Award, and also awards for Best Paper in various conferences. He is also the principal investigator in 2 ICMR trials and also has been a co-PI in 18 trials, including 2 multicentric international trials. He is also the editor of 3 Amazon bestsellers in ophthalmology and presently the editor Dows Times. Sir, over to you, sir.
Thank you, Dr. Rohita, for that kind introduction. Thank you, Professor Namta Sharma, ma'am, and Harshul, sir, for inviting me to this webinar. Now, it's a very challenging task to have a discussion on Malyugin ring with Professor Malyugin and then ask me to present on iris hook. But yes, what I would say nowadays, most of us do prefer rings, but there are certain scenarios where iris hook definitely gives you some edge. So I'll discuss only those cases here. So basically, iris hook, it has a polypropylene or nylon shaft with a silicone sliding stopper that gives you the locking as well as control mechanism, and you can control how much dilatation you need. And you have, for beginner, you have to remember the distal tip is angulated and this is little sharp. So if your chamber is underfilled, then you may hit the rexus, and there can be instances of rexus extension also. Single versus reusable, yes, iris hook can be reused, but officially it should be a no. Should use fresh iris for every each new patient. There are few practical points. Normally we use 4 iris hooks, but extreme cases you can add one extra, 5 to 6. And incision I'll discuss in the subsequent video. So this is a video, it's not a non-dilating pupil, but I have chosen this video because there are some learning points, as well as this gives you an idea about where are the cases where iris hook may hold an edge over the Malyugin ring. So it was a 4-year post-op case of pediatric cataract, you can see, with operated PPV for retinal detachment post-trauma. Now, initial surgeon, she had performed a in the bag IOL fixation with a CTR ring, but 4 years down the line, there is fibrosis and this entire bag complex is displaced towards the supero-temporal aspect. So, since it was a case of operated RD surgery, so we did not want to do much manipulation. We thought, why not fix this bag complex here? And the surgeon, primary surgeon, was my senior resident, Dr. Himanshu Khandelwal, and I was assisting him. So there were few learning points for the beginner here. So this is the flap that we have already created for back fixation. I'll just stick to the iris hook part. So earlier we used to make incision here at limbus, but subsequently now we prefer incision little bit we have posted to the limbus. Why? Because it prevents the tenting part of iris hook, because those who have used iris hook, they would understand if the incision is little bit entered to limbus, then what it causes, there is a tenting effect on the iris, which I'll show you in my subsequent video. So nowadays we make incision little behind the limbus, and it's always good to use a curved MBR if you have. Now, this is a very important step for beginners. What I'm doing is I'm injecting some Helon or high specific gravity viscoelastic between the space between the entry capsule. Here it's the bag and the iris. So when you are using iris in cataract, also you can create a space, but don't overfill it, but little space so that the hook can be easily inserted. Now, using iris hook, is you must know where your incisions are. So it's better that here I'm planning to put 2 iris hooks. So try to put all the iris hook inside the chamber and then try to dilate the iris. Now here there is one advantage of iris hook that I would like to highlight. Here I wanted a dilatation here only because I had to fix it the bag here and I needed to do all the manipulation in this quadrant only. So iris hook, it gives you an edge over rings or pupil expanders when you need sectoral dilatation, specifically in such cases where you want to do some extra maneuvers. So it gives you an edge. And second thing, yeah, okay, sorry. I'll just show how to remove the iris hook here. So while removing iris hook, you have to remember one thing: the iris hook is angulated near the tip. You have to follow the angle. Don't pull it vertically. If you pull it vertically, then what it will do is it will damage your iris. You can see in this video. Now, first you have to release the lock mechanism here, then relax your iris little bit and try to pull it out. But here you would see the surgeon was trying to pull it out straightforward like that only, and you should always avoid this. Don't try to pull it like this. Subsequently, you can see once you follow the angle of this iris hook and rotate it little bit, it comes out smoothly. So this is a practical point that one should remember while removing iris hook. Although very rarely we see complication, but you may damage the iris at times if you are not careful about the fact that there is a bending, there is a hook kind of structure in the near the end, and you cannot pull it vertically. Once you remove it following the direction, then it goes really smooth. So I'm skipping the back fixation part here. So this is the end of the procedure. You can see the CONU which was here, the CTR which was here, that has been pulled here. And here is the knot. This is the 10-9 of Berlin suture. This is an old video, almost 10-year back video. You can see. So these are another group of cases where your iris hook may be quite useful when the pupil is very small or polycarbonized, and there is iris atrophy along with some fibrosis in the iris, as previously it was being discussed. Another specific indication I feel in extreme cases of post-uveitic cataract, you may find a uveitic membrane or a fibrotic membrane forms at the edge of the pupil, and at times you may have to give multiple radial cut to relieve that membrane. In those cases also, iris hook may give you an edge over the pupil dilating devices. So it was a 2.8 entry. It was a case of IFIS, 80-year-old patient with tamsulosin and a floppy iris and a lot of iris atrophy. So I'll just show the iris hook insertion part. So as I was telling you, always to make a habit of injecting some viscoelastic in the space between the capsule and the iris, and then you can make incision. Here you can see my most of the incision are at limbus, not behind that. So when I'm pulling it, you can see there is some tenting effect of the iris here because the incision was little anterior. You can see the iris is getting tender here. So then the rexus, everything you can do it easily once your pupil is dilated. I'm skipping this part. So during surgery also that give you edge, but as I said, here there one extra iris hook could have helped the surgeon here. So in extreme cases of IFIS, you can go for 5 to 6 iris hooks, and you can always put one where your maximum working area is working space is needed. For example, in this case. Now, usually this iris hook, there is a tendency if you stretch too much, there will be damage, but in this patient, you will notice towards the end there is no such thing. The iris was again back to the same size as it was pre-operatively. Mostly you're not supposed to hydrate the iris hook incision. If you feel there is some leak, you can hydrate those side ports also. So these are the things that I have already discussed. You can use a MBR knife or a 15-degree blade. For manipulation, you can use the Kuglin or the Sinsky hook. Cohesive viscoelastic are of great usefulness. Complications, although very rare, you may damage the sphincter tear. There may be hyphema, and descemet detachment can be there, especially if you are not comfortable or you are just in the learning phase. Irregular post-operative pupil, if you stretch it too much, that may be there. And post-operative, there may be wound leak also can occur. How to prevent complication? I have already discussed. Use cohesive viscoelastic, avoid vertical traction, and don't let your chamber get shallow. So this is the last slide. I'll conclude here. So iris hook versus pupil expansion ring. So iris hook gives you control. You can adjust your dilatation. You can, if you want in one particular quadrant more dilatation, you can do that with iris hook, but that is not possible with your rings. Insertion is a problem because you have to create multiple incisions compared to no incision because you can use your main port only to insert the device. Special uses, yes, extreme cases of floppy iris syndrome or when the pupil is focal and small, in those cases it gives you an edge. Learning curve is easy. Cost is again low. Probably here also iris hook has little edge over the pupil expansion devices. But complications, mostly iris hook, the complication may be little higher compared to the pupil expansion rings. So with this, I'll conclude here. Thank you so much.
Thank you so much, sir. They were beautiful videos. I have a few questions, sir. Sir, would you like to do a square configuration or a diamond configuration when you're using the iris hooks?
As I said,
Yeah,
Can you
yeah.
unshare
the
your
full,
slide? Just unshare your, yeah.
yeah.
So if it is an extreme case of IFIS or very small pilocarboonized people, I would prefer a hexagon. But if it's a routine case, I just need a little more dilatation, then I would go for only a square configuration is good enough.
Praful, what about the fifth iris hook that you put just beneath the wound when the iris?
Yes, at times, as I said, if your entry points are little anterior, there used to be a tenting of iris, and when you are entering with your Phaco probe, you may encounter iris fold because of the two iris hook placed just adjacent to the main port. In such cases, also you can put an extra iris hook so that it doesn't keep on obstructing your Phaco probe or IA probe while entering into the anterior chamber.
What precaution would we like to take if we are doing it in a narrow palpebral fissure and we are trying to place iris hooks, then with each movement, the iris hook may dislodge or it may be a little difficult.
So I don't know if the panelists will agree with me or not. So I tend to cut the iris hooks little bit because
Yeah,
that
yeah.
gives you that space for manipulation, or else it will keep on getting each time you make some movement, then it keeps on hitting your capsule. And the thing you are scared about is it shouldn't extend the rhexis margin. So it's better to cut it or trim it little bit to accommodate for the small piece.
So you did mention one of the two complications, or rather the badder points of an iris hook is the fact that you're likely to have more of sphincter damage. Now, the sphincter damage, one factor that will cause a sphincter damage, irrespective of the pupil dilatation device, would be the fact that, you know, how sclerotic and how tiny is the pupil, right? How, Dr. Praful, do you think we can, irrespective of the cause of the small pupil or the tonicity of the small pupil, how can we limit the damage while using iris hooks, when using iris hooks?
I think the surgeons should not be too much greedy. Don't try to get a pupil of 7, 8 diameter.
Yeah.
If you give too much tensile force to stretch it, then that will damage the your iris structure. So
Yes.
try to get as much edge that can be useful to complete the phacoemulsification.
Yeah.
Don't try to overstretch it because iris hook, the problem is you can stretch it to the iris root also, but
Yes.
we don't need that much. If you avoid that, I think sphincter damage is rarely seen. I think whatever cases I have done, I have rarely encountered such damages.
I also think another little point is the speed with which we,
Yes.
retract the iris hook. We shouldn't be in any hurry to just wrap it up quickly. Obviously, you've got to decide how big your pupil is, which is the most valid point. I also feel if you do it slowly, slightly slowly, rather than suppose you put one hook at around 10 o'clock and you want to go and put the one at 8, you just don't pull it apart, even if not all the way outside very quickly. The slowness and the speed with which we, in a controlled manner, we open the second iris hook diametrically opposite the first, that also I have found can limit the extent of sphincter tear which should be induced by the iris
Is
hook.
very right. I think I mentioned that in the slide, but I didn't discuss that. Symmetric placement. Always try to place the iris hook so that your pupil dilates symmetrically. If it is at 3, then the second should be at 9. So that should be the one thing. And second, I feel even can use viscoelastic initially to little bit dilate the pupil and then use the iris hook. That can also minimize the iris damage little bit.
Also, you can put,
Yes,
in
that was
fact,
going to be
all
my
of
next
the,
question. In the case you showed with the,
Yes,
shaft iris inferiorly between the 4 and 6 o'clock position, you mentioned there that maybe you could have used another hook.
another
You
hook.
could have used,
Yeah.
you could have used another hook in the area where there was that iris chaffing. But
True.
sometimes even using 5 hooks, like a fifth hook between the area of chaffing, during the aspiration, the tags of iris are likely to come and get aspirated in either the phaco probe or the aspiration of the IA. Is there anything else that you could suggest we could do to tamponade and keep those tags of iris behind while continuing with phaco safely?
Injecting a visco adaptive like viscoat may give you
Yeah.
some
Yeah,
relief, but that is
I
transient.
think
To keep on reforming it again and again. And if you feel that these tags are not atrophic, then at times you may trim it using a vitrectomy cutter. Well, that will minimize the loss of iris during procedure if you trim those free floating iris fibers.
yeah, I found viscoat to be quite useful. A big blob of viscoat over there, at least for a few seconds, will help you quickly navigate some other steps until you, as you rightly said, you need to introduce a little more. Thank you.
And I
Thank
think also for beginners, I think it is better to just implant all the 4 or 5 hooks you into the anterior chamber and then slowly try to dilate step by step, rather than trying to put the first hook and then just trying to dilate that particular part of the iris. It's better to implant all the 4 or 5 hooks inside the anterior chamber and then go ahead. Have you any
There's a
time
question in
confirmed?
chat box, Dr. Rohita.
Yes, yes, sir.
You can take that.
In cases where you wish to place a hook in the area of your CC incision, would you prefer to use the same CCI or make another MVR entry beneath the incision?
No, it depends what the purpose of the first incision. If that is for manipulation, like you want to use your chopper through that, or you want to use the dialer to dial the intraocular lenses, then I think you'll have to make a fresh incision. But if that is just for purpose of injecting air, adri, and stain the capsule and no other use, then you can use that. But I would suggest you should make a fresh incision because normally the side port CC incision is little anterior near where the vascular arcade ends. And for iris hook, we prefer a little posterior or maybe behind the limbus incision. And even when you do it at exact limbal junction, it may not be self-seal. You have to hydrate it. So it's better to go for a new incision rather than using the first CC incision.
I
I
also
just want
will
to.
make a point, if I may.
Yeah,
Being
yeah,
a
Rishi,
cornea
of course.
specialist, while removal of the hooks also you should be a little careful. We tend to just, some people tend to just pull it off and you can end up
Damage
damaging
the
the
retina.
cornea or detaching the descens. So you have to negotiate it out. And I think,
You have to remember the curve. You have to
yes,
follow
you have
the
to follow
curve, then
the
it
curve
comes
of
out smoothly.
Again,
Okay.
this is a little offbeat question, but people do use iris hooks as capsular hooks. And I think that is mentioned in the chat box also.
Yes.
So at one point in time, all of us have done it when we didn't have access to capsular hooks. But I think capsular hooks is a different ballgame completely for capsule. Having said this, even the capsular hooks can cause damage to the capsule when you extend it too much. I think Suvira made a very good point that you should not extend your iris hooks excessively. I tend to put all of them inside first and then only, stretch them out later on rather than putting one and then stretching it, then putting the other, then stretching it. So if you put all four of them first and then slightly and lightly just try to stretch it out, then you are more controlled.
One thing I would just like to add here, as somebody pointed out that it can be used for capsule supporting. So even we also use that. But remember one thing, when you're using it to support the capsule, always prefer your incision little behind the iris. Or else the tip of the caps iris hook may be sharp, and if it causes a tenting and during phaco there is little bit pressure, then it may tear the capsule. So that is one thing. And it's always better to create a space before inserting onto the capsule by a gentle hydro or something like that between the lens and the enter capsule, and then insert your hook to support the capsule.
So there is one more suggestion which is coming, like you can stretch with Kuglans before inserting the iris hooks.
I don't think that's really
Yeah.
required because
Yes,
the
but
hook,
yeah, true. As
it,
Yeah.
Malyugin said, but if you are using a ring, then that may help you. In a very small people, you can stretch and then insert the dilating ring. But for iris hook, it's not required, as Dr. Subira said.
provided you don't have any posterior, like a seclusio pupillae, If you have something like that or a pupillary membrane, then you got to get rid of the pupillary membrane, break the synapse, and then you can hook it. If you've got a free pupil, however small, as long as you retract the iris hook stopper adequately, you can go and hook it wherever it is, however tiny the pupil is. You can go and hook it and very gradually just, extend it out. You don't need to dilate it any further, I don't think, at least.
Also, I think Praful mentioned, and there's a question again in the chat box. I tend to hydrate the paracentesis wounds or the incisions from which the iris hooks have been implanted. But Dr. Praful, you said that you may not do it, but I think that's personal preference. So
Yes, if you feel it's going to leak, then it's always good to hydrate. But
Mm.
most of the time, it's not required because you are not doing any manipulation.
Harshul, do you hydrate your side port wounds, or you don't use nylon hooks? You use only the Malyugin ring.
No. Sometimes I do. So sectoral use, which Praful was mentioning, I use in 2-3 conditions. Mostly, one condition is where subluxated lens is there, and first I need to, engage the capsular CTS segment. So many times I use iris hook to engage that CTS segment and then uh, fix it later on. So that's one. And of course, as you rightly said, I also agree. I do tend to hydrate whatever, however small the incision is, maybe little, just little hydration, and it's enough. I
Sometimes in
think
cases of IC syndromes where there is a lot of atrophy uh, and the pupil is not dilating, then which would be the preferred choice of pupil expansion device?
If it's a acid, yeah.
Iris hooks.
Yeah, I think if you have the possibility of a symmetrical expansion of the pupil, then I would use a ring. In any kind of gross asymmetry, I think as a take-home message, at least for students who are learning until you get good and can play around with different things, if you've got a sectoral need, as Dr. Prafula said, or a gross asymmetry or significant posterior synecdoche, I would just tend to use iris hooks too.
Yeah, in fact, if you have very strong synecdoche, you may not need to use too many iris hooks. You may just have to use on one side, the synecdoche itself will work like a hook. So you may just need to use it on the opposite sides, maybe 2 or 3.
I think we should move to the next talk now. Yeah. Thank you so much, Dr. Praful, for this wonderful talk.
Thank you, ma'am.
Yeah. Dr. Neeraj? Yeah.
Yes. Thank you, Dr. Rohita, for moderating the first half of the session. Dr. Harshul, sir, thank you for the opportunity. I think this is your brainchild when the going gets tough. I think now moving ahead to the next talk, I would like to introduce Dr. Rishi Swaroop, who is the medical director and chief surgeon at Swaroop Eye Center, Hyderabad. He has got his MBBS with a gold medal in surgery and a gold medal in final MBBS, followed by various associations with the FRCS Glasgow that he has come across, a long-term fellowship in Shankar Netralaya, Chennai. He is the chairman, scientific committee of Telangana Ophthalmic Society. He also has a past chairman ARC in the same Telangana Ophthalmology Society. He is also on the editorial board of the IJO, that is the Indian Journal of Ophthalmology. His achievements we've all heard of, that started right from the Achievement Award at the AAO 2013, followed by the CS Reshmi Award in Hyderabad 2013. He's also been awarded the IRSI Gold Medal Award in New Delhi and Chennai, both. He's also got various oration awards like the M.M. Joshi Award, followed by Dr. O. Gopal Krishnan's Lecture Award. And also, yes, of course, we've been constantly being in touch with his achievements internationally. That is the Achievement Award once again, after probably Asia Pacific Academy of Ophthalmology 2023. Apart from that, yes, he has a little bit of other interests which we keep on coming across, that he's a nature lover and a photographer. So today he's going to talk on the B-Hex ring, and we are eager to hear his take on the B-Hex ring with the presence of Dr. Suven sir, who is the inventor of the ring. So over to you, sir.
Thank you, Neeraj. And I'd like to thank Namrata and Dr. Harshul and the scientific committee for giving me an opportunity. I just put on my presentation. Are my slides visible?
Yes.
Okay, so I'd like to thank at the outset Dr. Suven Bhattacharjee for really inventing such a wonderful device, and that too it's made in India, so it makes us all very proud. And every time I have to choose, I end up using this one or one of the Indian devices because one of us has made it. And it not just for that reason, it's actually a fabulous device, and we'll discuss some of the pros. He's also been kind enough to lend me a few of his animations, which I've used in this presentation. I hope my video is showing here. The animation is playing, isn't it? I'm
Yeah,
just checking
Rishi.
the internet.
Yeah, it's
Yes,
playing.
okay, fine. So as we know that he has invented 3 generations of this device. There's the original B-Hex, and then he developed the 2.0 version, which is slightly thicker and stronger and gives us slightly more dilation. And then the recent addition to this family is the B-Octa, which gives a octagonal dilation of the pupil, which essentially will, one second, I didn't realize my laptop is about to die. I'm just going to just keep it in. Yeah, so the octagonal dilation of the pupil gives a much larger dilation and can even be used for SICS. So it's the way it is slightly superior to Malyugin ring, I feel, is because of the thinner profile. It's much thinner, as thin as the human hair, as you can see in this picture, 75 microns. And the second big advantage is it does not make the iris contort to its shape. Rather, it contorts the shape of the iris. So some flanges go below and some flanges go above. And that really makes much more, I would say, ergonomically less intrusive in the eye, and especially when your working space is less, like in smaller, shallow ECs. Sometimes you have angle closure glaucoma cases that have had a yak PI and they don't dilate. Such kind of cases, I think it really helps to have a thin device. Also, because it's very small and thin, it goes in through smaller incisions, and you don't really need a larger incision to insert it. So this is one of my earlier videos that I'd made for Suven. I'm not sure if he's still around, and he will remember this video. So this was the first device, and at that time we used to insert the device with the help of these manipulators, which look like Sinsky hooks. So this was a patient of tamsulosin, and Suven had just sent me some samples. So I started the Rexis, and I realized that the pupil is moderate size and iris was floppy, so I didn't want to have a problem. We decided after the Rexis and after any meeting, we inserted the ring in, and it comes in a nice little housing like this, and you can just initially we used to push it in with this Sinsky hook like manipulator, and then of course we have to put viscoelastic under the iris to make space for it, and then you have these little dialing hole like things on the flanges with which you can engage the manipulator and tuck alternate flanges in. And the third one used to be a little bit of a challenge with the manipulator. And I think that's why we kind of moved towards a different kind of a insertion in which we the forceps. The B-Hex device also comes with a 23 gauge curved forceps that this was the B-Hex forceps that is specifically available with this device. So you basically, in a controlled manner, go through your paracentesis and just engage the hole or the flange and just put it in. In this case, I'm taking the flange, but In general, it's better to use one of those holes. Keeping the holes in front is advantages that if you want to dial the ring a little bit, it comes in very handy. So as you can see here, you get a nice perfect hexagon. So you'll get about 6.5 or 7 millimeter pupil in most cases, which is reasonable for getting a good rhexis and doing all the steps of Phaco, including the IOL insertion. After that, you can just disengage the superior flange, 1 or 2 flanges, and then you can just grasp it and remove it. So this was a patient of post-YAG PI, small pupil, as you could see the pupil superiorly. You can see that it's very easy to insert, and I also tend to reuse these devices. I'm not sure if Suhail will be happy with that, but we can ETO and reuse them for at least 4 or 5 times. After that, sometimes it loses its flexibility and may not be so easy to use. So I'll just show you a couple more videos. I will run through them. So this is a patient of IFIS. I think in IFIS, pupil expansion devices really have an important role to play, and especially I think B-Hex is very useful because of its thin profile. So we insert it like this into the eye, and then you can use these intraocular forceps to just engage it and just put it in like so. And then again, you get a perfect round rhexis. And all the steps of phacoemulsification can be done very easily, including insertion of the lens. What I wanted to show you in the end is you can see the pupil almost becomes round, just like virgin pupil. Very, very micro sphincterotomies you may get, but when you see them just on the outside, on external light, you won't even realize that the pupil is distorted. It looks almost round and perfect. So because of the thinner profile, it also distorts it lesser. Yes, it may not expand the pupil as much as you would get in thicker devices, but for most cases, I think this is more than adequate, and especially for challenging cases such as floppy iris. I'll just show you one more case of floppy iris. This was actually a patient who we chose to have a femtocataract. So I decided that if the pupil is not large enough, I would actually go in first, put cohesive viscoelastic, put a B-Hex ring, and then do the femto firing, which we can do with our device, which is the Zima 8, which can be fired in a sterile manner in the OT, and then proceed. But luckily for me, the pupil was large enough to get a reasonable rhexis. I think we got about a 4.8 rhexis or so. So we managed to do the rhexis, and then I knew that this is going to be a case of floppy iris, so I did want to put in a ring. So here we've just taken out the rhexis, and then I can see that the iris is already trying to pop out. So at this stage, I decided to put in the device, as you can see here, and then we just engage it with the forceps like so, and you can get a nice, good exposure of the entire rhexis, and you can perform a safe cataract surgery, as you can see in this video, and insert the lens. And after that, you just disengage and remove the whole thing, and you can see that the pupil is nice and round, as though nothing has been done at all. So coming back to the presentation, I think it's a nice device. Of course, Malyugin is also wonderful, and we've got an Indian version of the Malyugin also called the Gupta ring, which also works quite well. They've come out with the newer version of the B-Hex called the B-Hex 2, which is got slightly thicker, stronger flanges. So it's able to dilate the pupil a little better, and you get a slightly larger dilation, and it also may be useful in more rigid pupils. And of course, now we have the new device called the B-Octa, which gives an octagonal dilation, unlike the Hex, which gives a hexagonal dilation and also gives a much larger pupil. And so it has also been recommended that it could be used for small incision. I have not tried it for that, but I have tried it for some other cases, like this particular case of a pseudo-exfoliation with hypermature cataract and suspected zonular weakness as well. So in this case, I'll just show you. Sorry about the. So you can see that we've just done the rhexis, then stained the capsule and then inserted the device into the eye. And it's got these 8 little notches, and you can one by one insert them using the forceps. So forceps actually makes it very easy. And if you can use both your paracentesis, it's very easy to insert. And you can see you get such a huge pupil, which may not always be necessary, but in a case like this, intermittent cataract, where the likelihood of run out, you want to have a good exposure so that in it does run out, you can pull it in safely. So in this case, of course, we're doing the double access, which is the ideal technique to use in such cases, and we managed to do the case quite nicely. I'll just show you one more video of Dr. Pradeep Mohanta in which he's using it for small incision. I haven't used it for this indication yet, but just to show that the whole nucleus can also come out through this B-Octa device quite nicely. So I'll just show you one more little video of B-Octa. I've only used it in 2 of my cases. So this is my second video in which I'd already inserted it first. And you can see that the first 2 flanges are already in. Sorry, the video is not playing. I think we can skip it because I've already shown you another video. So that's about it. I just thought I'll show you some videos to kind of give you an idea of the device. It's actually a very easy device. Anybody with reasonable surgical skills can use it. Sometimes the last flange can be a little challenging in some people. So what I do is I turn it around and bring it to my dominant hand, and that makes it a much easier to kind of do. And you can use a counter pressure with another second instrument to kind of just make it a little more controlled. So fibrotic pupils can be a little bit of a challenge. So what is recommended is to use a stretch like a Pupil Phaco, stretch the pupil and then use the device, and that is. And then once you use the device, it won't be floppy, so it will keep it in place. And so B-Hex and B-Octa are excellent made in India devices, and which help in all kinds of small pupils and floppy iris situations. And I think one real advantage is in femtocataracts, where you can actually go in before you fire the femtocataract, make a small incision, put it in, and then go ahead and do the rest of your femto firing procedure. The thin profile allows for easy insertion and removal, and you can reuse it multiple times. It's a game changer. The B-Octa is a game changer when you really need a big pupil, like in situations like SICS. And these devices can be used in conjunction with pupil stretch for fibrotic. Thank you.
Thank you, Dr. Rishi Swaroop. I think very well presented and very well portrayed our very own Indian innovation by Dr. Suven. I think I have a question for all the panelists over here. You presented, before we go to Dr. Suven and his comments, if Dr. Suven is available.
I'm available.
Yes, sir. So
He's
this question
always
is
there.
probably for you also. So out of all the cases, there was one case on pseudo exfoliation. I had a query that in case your case was probably a moderate pseudo exfoliation, but in case of an advanced pseudo exfoliation, so this is also for you. Now the contact point of the B-Hex is probably like a notch, unlike if you see a scroll in case of a Malyugin. So would it what about the cheese wiring risk? Because there is the iris is more friable. So would it be better to use the B-Hex or a Malyugin in case of an advanced pseudo exfoliation case?
I don't think
Can I
it
answer that?
fire. It's a very thin device and it doesn't exert so much of stretch on the pupil, in fact. So I've not seen that. Maybe Dr. Suven
First of all, if I may.
Yes, sir.
Yeah, so a good question, but in pseudo exfoliation, the iris is not friable. Iris is not actually weak. It's actually the pupillary margin is more fibrosed than others. So you need to stretch the pupil. So it's not that the iris is weak or the cheese wire. That's one. B, the B-Hex is actually the safest and the most gentle device among all devices. It's the thinnest device, so it doesn't have the mechanical strength to actually damage the iris. And that's the reason why you see that the pupils are absolutely, they look pristine even the next day after surgery. They look untouched. So there is no risk in pseudo exfoliation at all.
Okay. So I think apart from that, I would just ask Suven sir about his inspiration on this device. And yes, again, the same question that for a beginner, how would a beginner go ahead and what to do and what not to do with the B-Hex ring?
Okay. A good question. So, as for my inspiration, well, yes, I wanted to make pupil expansion easier for all of us. and I think we've achieved that significantly because it's something which does not require too much of skill. Average skilled surgeons can easily take to a BX, a microsurgical forceps, which comes to us very easily. We are used to using microsurgical instruments. You don't need all the manipulations and the supination and pronation of a Malyugin ring with an injector or other devices. So it's simple, hold the flange and tuck it in. So it comes very intuitively to us. So that was one thing. So make a very simple device. And the whole idea was to make it machinable so that the costs come down. And that again we have achieved. Now, as far as beginners are concerned, it's just you. Now, I think for the past 1 year or so, we've been having a few wet labs, but we started in 2017, and for a good, I think, 7, 8 years, we never had wet labs. We never had hands-on demonstrations. Surgeons would just watch videos and do it. So it's as simple as that. There is hardly any learning curve. So if you're used to anterior segment surgery, if you're doing phaco surgery, there is no way you'll find using a B-Hex any different or difficult. It's just grabbing the flanges with the forceps and tucking them in. No rocket science in that. And of course, now we've got some wonderful videos by some stalwarts over here. Rishi, I must thank Rishi. Rishi was one of the earliest to use. In fact, many of you wouldn't have seen the version of the device that he showed. That was something we called end hole flanges and hole flanges. Those are obsolete now. So Rishi was one of the earliest ones who tried the device. So thanks to Rishi for making it popular then.
Thank you, sir. Before we go on to the chat questions, I would like to also have opinion of Namrata Sharma ma'am and Suvira Jain ma'am on this beautiful Indian device that has gone global now.
I completely agree. It is definitely not difficult to do. If you're a surgeon well versed with anterior segment surgery like phacoemulsification, working in a closed chamber, if you got your depth perception right, then handling a B-Hex ring is a piece of cake. And I completely agree. We've all learned by just maybe perhaps initially making a call or two to Subin and saying, hey, this, hey, that, there seems to be an issue. Am I getting this right? But now the way there's so much on YouTube where you can go and see so many people doing it, including showing challenging cases and challenges while doing it, that you can just go ahead and do it. I would completely agree.
Thank you, Suvira.
Dr. Namrata ma'am, any experiences in your practice with the B-Hex ring?
I think Namrata ma'am is busy in another webinar.
We'll probably take one question from the chat then.
Yeah.
If it is the case of intumescent cataract, are there any precautions to be taken before injecting the B-Hex ring? Again, I think
I think it's important to kind of just put some OVD between the iris and the lens, Otherwise, accidentally you could end up injuring the capsule while inserting with your forceps might rupture it because it's so intumescent that sometimes it ruptures on touch.
Absolutely agree with you,
Important
Rishi.
to stain before you put anything.
Yeah, I think what's more important, Dr. Neeraj, a good question. Actually, Rishi has pointed out very correctly. We need to just, normal cases, you could probably inject viscoelastic once and get away for the rest of tucking. But here, probably you need to top up the viscoelastic with every tuck so that you're absolutely sure that the iris is off from the anterior capsule and you do not exert any pressure because the capsule is just waiting to tear.
So I would just rephrase the question. What about an Argentinian flag sign? How would we, in case of an Argentinian flag sign, what precautions would you take while putting the B-Hex ring? Because usually what happens is that the transparent nature of the B-Hex it provides a visual advantage during the first cut of the capsulotomy. So how would you go about it?
You're saying after the ring has been put, you've had one, or you're putting the ring in after you've had your Argentine flag sign?
Probably both cases. Now that you said, probably both.
It's a free for all then. Okay, so let's say if you have an Argentinian flag sign, when you have the ring in place, well, you've got an exposure. And it depends upon whether you want to carry on with your phaco or abort and do something else. But if you're going to abort and do a SICS, with a B-Hex, it might be a challenge because the nucleus may not come out through that 5.5. You have a B-octa in place, it's going to be a piece of cake. because for SICS it's going to be fine. If you want to pursue your Phaco, well, you've got a pupil expansion and you go ahead and you take the standard precautions as you would with any other case. Make sure that the chamber is well maintained all through, and the tear is not a wraparound tear. So you keep trying for that. If you've had an Argentinian flag and then you want to put a B-Hex or a B-Octa, it is going to be a challenge. The whole idea is again to keep the iris off from the anterior capsule and make sure that you're not grazing the anterior capsule as you go in, because then that's going to extend the Argentinian flag. And lots of OVD, lots and lots of OVD, so that the anterior chamber is well maintained throughout. I think that would be my mantra.
I would say in all intermittent cataracts, you should use the B-Octa. I think you need to have good exposure, because you can have capsular misadventures in these cases, and always better to have a good visualization if things run out or things go out of control.
Yeah, and I think if you've got a pupil which sometimes we can just tell has a potential of getting smaller, you just know, I'm going to put in some visco and it's just going to get smaller. Then in a case like that, you're safer putting in a B-Hex ring to start with and then going ahead with your capsular rhexis, because anyway a capsular rhexis with a very intumescent cataract is going to be challenging. The question of then wanting to put in a ring after you've got an Argentine flag sign somehow doesn't fit. I'd just be more cautious. If I had the slightest of doubt, even now, I would get my pupillary expansion, and I would like to work in a more controlled environment where I now have an intact anterior capsule in an intumescent lens, which is with a pupil that is not only dilated, it's going to remain dilated thereafter. Thank you.
Dr. Harshul and Dr. Namrata, I think Dr. Namrata ma'am is back. Any experiences about the B-Hex?
I have used, and Suven was kind enough to send me the B-Hex rings, and I have used them, and I think they are a great device. I think they give you more flexibility, and I feel that the pupil dilates more than the Malyugin ring because of the fact that it also has its own tenacity. So Malyugin, between the two clips of the Malyugin, there is only a limit to which the iris can stretch. But between the segments of the B-Hex, it just tends to dilate a little more. I think the first generation that I used did have some amount of learning curve, but now I think as it has evolved and as the modifications have come up, it is only getting better.
Yes.
So congratulations to you, Suven, and thank you for.
Thank you very much, Namrata. Thank you.
I
You've been a
remember
great support throughout.
many years ago, many years ago, you wouldn't remember, you presented it in a Kolkata meeting, OSWB meeting, for a video competition. And at that time, you were talking about the patent, etc. And that was so new to any one of us. We had no idea what you were talking about. I mean, but you worked on from that idea, and great.
Thank you very much, Namrata. And actually, I must thank everybody in the All India Ophthalmological Society, all our colleagues over here. The support has been immense, and that's been our driving force. When you do something and people use it, and I get a message on my WhatsApp or chat, and somebody thanks me, somebody who's about 20 years younger to me, and thanks me for something, it makes my day. It makes my day. Thank you, everyone.
Thank you so much,
Great
Dr.
job.
Suven.
Thank you, Suven.
Yeah.
Thank you.
Let's move to the next talk, Dr. Neeraj.
Yes, sir.
Right. I'll be signing off. Bye-bye.
Thank you so much.
Thank you so much.
Thank you. I'm at a party.
Yeah.
So I think let's move on to the next talk. So Dr. Srini Idakilan needs no introduction. He's the Chief Surgeon and Medical Director at Malhari Eye Care, Kerala. Of course, he's a high volume surgeon, more than 130,000 phaco emulsification surgeries, member of management committee of AIOS. He was also part of he was a joint organizing secretary of the AIOS Kochi, which was so memorable. Not only this, but he's also the editor of the Kerala Journal of Ophthalmology in the year 2021 and the Honorable Secretary of KSOS 2018-2019. Now, Dr. Srini is going to talk on phaco in small pupil. So I think it's going to be very interesting for youngsters also watching this. And over to you, Dr. Srini.
Need to unmute Dr. Srini.
Thank you, Neeraj. Thank you, Harshul. Can you see my video?
Yes, yes.
Okay. Thank you. So many innovations, so many dilating devices. Why should one actually do surgery without any of this? See, I mean, everyone would one day or the other end up doing surgery without these dilating device. Even a surgeon of my ordinary skills sometimes get really overconfident and feel okay. I can get away without dilating. So when you are doing these surgeries, you have to take care of some aspects, and also there are some complications that can happen other than your PCR and all. I'll just show some videos so that we can all understand what can happen there. So this is quite a small pupil. And now I'm seeing the video. I don't really remember why I did without any dilating device, but I did it. I mean, here the most important thing is the capsular access. We should get at least 4 mm. I'll show you how to go about it in the next video. And the hydrodissection has to be very careful. And I will never even dream of doing a Phaco without any dilating device if it was a very soft cataract. I will do it only if it is a choppable nucleus, and I go for a direct chop in all these situations. If you don't get the chop in the first go, you go for a multi-level chopping, and you have to get a proper chop to do a safe phacoemulsification in this case. So the nucleus is divided, and then once you have a nucleus division, everything is goes off quite easily. The most important thing is to have a very safe anterior chamber, stable anterior chamber. So it might be a good idea to reduce the aspiration a little bit, and see the phacoing of the nucleus is once you get a proper access, proper hydro, and nucleus phaco is not that very difficult. The challenge comes in the cortical aspiration. So I would go for either bimanual cortical aspiration, or I love using Simcoe in these cases, and you get and here is the biggest challenge. The IOL has to go into the back. So the leading haptic has to be directed into the back, and once it goes in, the optic also goes in, and it has to go into the back. So this is not so small. This is neither here nor there situation. You wouldn't actually blame me for doing a phaco without pupil expanding device in this case, because it's almost nearly 4 mm, and this is the way that Rex is. You're not going along the margin, you just go just beyond the pupillary margin, then come back. You don't go really under this thing. It has to be under your control, and this is pupil is large enough. So my go-to hydro procedure is cortical cleaving hydrodissection. Here I went for that. When the previous one, I was really careful because nothing was really visible here. Here again, it is a choppable nucleus, and I always go for a direct chop in these cases, and it's always better to keep the phaco tip in the center of the pupil. You go more near the pupillary margin. If you catch the pupillary margin, then it has a tendency to keep coming onto the phaco tip, and it's also better to keep the phaco tip a bit above the pupillary plane, because you don't want the fluid to go under the pupil and the iris to below up. So it's sort of not in the back phaco. So it would be a good idea to use something like visco to protect the endothelium in these cases. And so, see, once you get a good job, one piece, then it's quite easy. And here, that small piece don't go with the phaco tip to search for it. You manipulate it with your second instrument and then feed it into the phaco tip, which is mostly staying in the pupillary center of the pupil here. It's to prevent you from catching the pupillary margin, iris tip, and all. Again, here, see, and the incision for the Simcoe is about 1.2, 1.3 mm. It's a little bit larger than your biomanual, but I would either go for biomanual or Simcoe in this case is not a coaxial. That's my preference. And the IOL has to, the leading haptic has to go into the back and make sure that it is there. So this is another case. I mean, pupil is not as large as in the previous one. And the rexes, again, it's a good enough rexes. You go under the iris, then come back, then again go under the iris, come back. So that you have a 4.5, 5 millimeter rexes, which makes the surgery safe in these situations. But as the surgery was proceeding, I found it actually difficult to rotate the nucleus. So see, it was not rotating. See, when does it rotate? If there is a PCR, but I decided not to. No ego issue here. Put an iris hook. There was nothing, and I could finish the surgery very, very comfortably in this case. Here, there was a pupillary membrane. I removed it. It was not really dilating fully. Just did a stretch pupilloplasty, and it worked well. So here, the pupil is not that very large, but I just wanted to show you some. See, if you go, you saw the pupillary margin iris being caught. So this is a danger if you go with the phaco tip near the pupillary margin. Make sure that you stay at the center. See, this case came to me about a month after cataract surgery. Everything was fine, 6x, and the patient had a high IOP, and you can see in the anterior that there is a haptic out there. So it was a smallish pupil. Everything went off well. I thought the IOL was well in the back. It was, but one haptic was sort of popping out. So the patient was taken back, put iris hooks. This time I didn't make the mistake of not dilating the pupil. And it was dialed back. The whole IOL was dialed back, and in a month's time, this is the post-op. In a month's time, I could take the patient on off anti-glaucoma medications, and so these are some of the lessons that maybe I learned, or you can see there. So the thing is, you have all these pupil dilation devices. The first, you should go for them.
You don't need them, Srini.
No.
If you had shown us this as first presentation, we would have said, okay, let's call it a day.
So this is see, the problem is in the making sure that IOL goes into the back, and also you should in the end, when you're doing the aspiration, look out for see, bit of cortex here, there. You have to do a proper cortex wash. There might be small nucleus bits hiding behind the iris. and maybe 2 weeks or 1 month later, the patient will come with the localized corneal edema there. You will wonder what is there. So if it is a small pupil, make sure that everything is cleared. So that is something that you should be doing. And so one more thing, like I didn't want to enter during the discussions before. There was a discussion, a question on using iris hooks for capsule support. The problem with using iris hooks for capsule support is that unlike a capsular hook, it doesn't protect the equator of the capsule. So I know there are a lot of we can call them juniors listening to this. The problem there is that we put an iris hook, which is a large zonular dialysis. You put an iris hook, and if you don't put a CTR in the end, you will get the equator coming into the phaco tip. So it'll be sort of a double jeopardy. You have a zonular dialysis and you'll have a PCR. So if you have access, you should have access to capsule hook. That should be something that you should be going for.
Thank you, Dr. Srini. I have one question to ask. So many cases done without any device. What are those red flags that you notice on the slit lamp before, apart from a small pupil, and you decide, okay, I'm probably not going to use any device today on this.
I see most of them on table only.
Oh, okay. I mean, if Harshul sir can answer this question, that what should probably seen on the slit lamp itself that you should decide, okay, I'm going to use, because in your hands, yes, probably you don't even need a device. But
see, I think whenever we see patient on slit lamp, first, of course, we have to see patient of pseudo exfoliation. Then you should see the pupillary reactions, what is the size of pupil and how it's reacting. So usually those pupil which are rigid, they react very less to light. So that gives you clue then if patient is diabetic. And of course, we do ask patients always, all the time, we do ask if they are on any drugs for, tamsulosin or like that. So these are the things which you always look for in patients. So, and our threshold is very low. It's not that, as Shini said, in cataract like this, we can always do. I use 1.8 mm phaco tip. So for me, even if it's a 2.5 pupil, 3 millimeter, it looks bigger to me. But the thing is, no one can make out the perfect size of rexes. No one can, be sure. But if it's a harder cataract, we can easily chop it. But as Shini said, it's a soft cataract, you are gone. You can't, trench it properly. You can't divide it properly. So if you are in a situation you don't have device, one fine day, it's fine. You can do, what you need to remember the principle that you should be in center of the pupil, as Shini showed. You should be always careful while taking out each and every piece. You should you have to retract iris and look for pieces here and there. Otherwise, they may come up after a month or two.
Also,
so these are all things.
You see, here, one reason why people might avoid using all these pupil expanding devices is that, say, we have a feeling that it'll take more time. But finally, if you don't use it, also,
it'll take more time.
It will take time. So it's though I've shown so many videos, I was not showing off absolutely. It's just that it happened during surgery. It was recorded there. I showed it, and I wanted to show what can go wrong in these cases. So if you feel that not using iris hooks and all is going to save time, no,
it does not.
It's not going to save time. So it's better to use.
Dr. Savira has something to say now. I want to ask her trainings residents also with these devices.
Well, first I'd like to say, Srini, you do not show off. That's for sure. I'm very privileged to have you as my very, very close friend. And you are an exceptional surgeon. There is no doubt about that. But Having said that, when you're looking at maybe the 119 attending here and many of us up here as well, safety while performing phacoemulsification surgery or manual SICS surgery comes from visibility. The more you have a clear visibility of what you're doing, the safer you're going to be. Many surgeons do not even like to or know how to or want to change to doing direct chop. So since many surgeons are still stop and chop surgeons, which is a great technique, it's a personal choice. Dr. Vasavra has taught us stop and chop. I do stop and chop. I prefer direct chop, though, like you. But for those surgeons who are even trying to do a stop and chop in their routine surgeries, they're never going to manage in a small pupil. The other challenge is if you've not seen where your rhexis goes and you're not as experienced as you are, Srini, your rhexis starts to go out towards the periphery in such a small pupil, no one will have any clue how to bring it back. So given those factors and the fact that phacoemulsification is not as easy as you make it seem, we want students out here who are tending to have adequate visibility of what's going on. And when you really, like I use iris hooks a lot, amongst other things, in 2 minutes I can put it in and out. That only comes from your experience of doing them. So even to get your confidence in using pupillary expanding devices, which is then going to reduce your overall time, it just is a matter of experience, is my very humble opinion. And you're wonderful.
No, Suvira, thank you. But one practical issue here is that when these kids are going in for fellowship training or they're doing, many of them might not really have access to these devices.
No, iris hooks is just 300 rupees, no?
Yeah, Harshul, but
So any device. So the message, so that's what.
No, that is fine. I think we gave him a tough topic of doing small pupil phaco without devices, and he did it very well. But then that is to say that if you're still in your learning curve, do use the devices. But I do remember, Rashul, in one instruction course in ASCRS, I had a talk on small pupil phaco, and I showed all the devices. And then the question was, but you can still do without the devices. So it was like, I did not include a video like Srini's where small pupil phaco was done without devices. So that is what the way it is. I mean, it is possible to do, but of course you have to be as experienced as Srini to do it.
Fine.
So where is the Google form people are asking? So if we can just tell them.
I think Mr. Sunil, you are there?
Yes, I'll just put it.
Okay, so we come to the end of this module 2, and I'll request Mr. Sunil to share Google form in chat box. So all the attendees, thanks for being there with us, and we hope that you loved all the videos which are presented here, and we'd like you to take up these questionnaire. These are 15 questions. You need to finish in 5 to 6 minutes. After that, Google form will close. So we are putting up this Google form on Zoom as well as on Facebook and YouTube also. So Mr. Sunil, can you please share the Google form here?
All three done, sir.
Okay.
So I think, Harshul, we've had a great audience and a very glued audience. You saw that at no time did the numbers, they fluttered. So I think that is mainly because of the format of the whole course, and thanks to you for that. And I think if in any way we are welcome to suggestions, if anybody wants to give suggestions to change the way that we are doing it, we will be more than happy to do it. So Harshul, concluding remarks by you.
No. Before that, whoever is attending, please see Suvira's
you can
videos on YouTube.